Chronic kidney disease, or CKD, affects approximately 10% of the world's adult population. In South Africa, estimates are that there are more than 6 million people living with this disease. Now, sadly, about 9 out of 10 people who have chronic kidney disease may not know that they have the condition. CKD is the 12th cause of death worldwide, and its impact on patients and their families can be devastating. Over 2 million people worldwide currently receive treatment with a dialysis or a kidney transplant to stay alive, yet this number may only represent 10% of people who actually need treatment to live. Now, today we discuss kidney disease. And to help us understand this condition better is an expert panel comprised of a consultant nephrologist based at Helen Joseph Hospital, a nutritionist, a kidney transplant coordinator also from Helen Joseph Hospital, a kidney donor, and 2 dialysis patients, and one accompanied by his wife, who will all share their experiences of the impact that this condition has had on them and their families. You can tweet us at SABC Health Talk, or simply just interact with us on our Facebook page, SABC Health Talk. So sit back, relax, and learn from this bumper show coming to you just after a short break. I'm Dr. Salomo Daung, and this is Health Talk.
Every woman wants beautiful brows. There's flawless brows from Finishing Touch, the new gold standard and first precision hair remover that instantly and painlessly sweeps away unwanted hair. The finest German-engineered technology that erases unwanted hair with micro-precision. And with an 18-karat gold-plated head, it's hypoallergenic and gentle on all skin types.
Get your Flawless for only 249 Rand from your nearest Verimark store today.
Did you know that the Egyptian pyramids are ancient pyramid-shaped masonry structures located in Egypt? It is generally agreed that pyramids were burial monuments for the pharaohs and their queens. There are about 80 pyramids known today from ancient Egypt, with 3 largest and best preserved built in Giza at the beginning of the Old Kingdom. The pyramids of Giza represent one of the greatest architectural feats by man. Until the Lincoln Cathedral was constructed in England in 1311, the Great Pyramid of Giza held the title for the world's greatest man-made structure.
Chronic kidney disease, or CKD, affects approximately 10% of the world's adult population. In South Africa, estimates are that there are more than 6 million people living with this disease. Now, sadly, about 9 out of 10 people who have chronic kidney disease may not know that they have the condition. CKD is the 12th leading cause of death worldwide, and its impact on patients and their families can be devastating. Over 2 million people worldwide currently receive treatment with a dialysis or a kidney transplant to stay alive. Yet this number may only represent 10% of people who actually need treatment to live. Now, today we discuss kidney disease, and to help us understand this condition better is an expert panel comprised of a consultant nephrologist at Helen Joseph Hospital, a nutritionist, a kidney transplant coordinator also from Helen Joseph Hospital, a kidney donor, 2 dialysis patients, and the wife of one of the dialysis patients will accompany the husband, and they will all share their personal experiences of the impact this condition has had on them. You can tweet us at SABC Health Talk, or simply interact with us on our Facebook page, SABC Health Talk. Sit back, relax, and learn from this bumper show coming to you just after a short break. I'm Dr. Solomon Daung, and this is Health Talk. Welcome back. We're talking chronic kidney disease, and in this segment, we're going to be talking to people that are actually affected by this condition. First up is Caleb Ryan. Now, Caleb is on peritoneal dialysis. Well, Caleb, welcome to Health Talk.
Thank you for having me, Doctor.
Right. And Caleb is accompanied by her wife, Imelda McLaren, and she's going to obviously share experiences of what it is like to look after somebody with a chronic kidney ailment. Welcome to Health Talk, Imelda. And of course, we also have Josephine Tselane, who herself is undergoing hemodialysis. Welcome to Health Talk, Josephine.
Thank you for having me.
All right. Let's start with you, Caleb. Tell us about yourself. I mean, when were you diagnosed with a kidney problem? What happened at that time?
2 years ago, I was diagnosed with kidney issues, that my kidneys wasn't functioning.
What did you feel at the time? What was troubling you? What sent you to the doctor?
First of all, I was very tired.
Right.
I couldn't walk a short distance, say 2 meters for the most. I couldn't walk, and my legs were swollen.
Right.
As you can see now, I've lost a lot of weight, but I can understand because the doctor explained me that was due to water that was inside my body. But it has been a very tough journey.
Yeah.
And
that time, just think back. You see that you're getting tired, your legs are getting swollen, and decide, it's time for me to go and see a doctor. And what did you go through? I mean, were you hospitalized at some point?
Yes. You see, the thing is, I'm diabetic. I'm a known diabetic.
All right. So you've been diabetic for
quite a long time, more than 15 years. And I've been managing the diabetes quite well because my sugar levels is below 10 on a daily basis. I measure it like 4 times a day. Yeah. So the doctor did explain to me when I was diagnosed with diabetes that complications will arise because your diabetes will affect your other organs, and so I was aware it's gonna eventually happen. Right. So when I wasn't feeling too well, when I was like tired and when I swollen up, and I went to the doctor, that's when they told me no, and I had water on my lungs. Right. Because of too much fluids in my body. So then the doctor told me, no, this is your kidneys is functioning at 5%, and unfortunately you have to go on dialysis with immediate effect. Okay. I would like to thank the staff and the doctors at Helen Joseph, because if it wasn't for them, I wouldn't have sat here with you right now, Doc.
Right. So you've been on dialysis for the last 2 years?
Yes.
Okay, all right.
No, actually a year. I was diagnosed a year ago, but there's a workup procedure that you have to go through in order to get onto dialysis.
So give people a sense of what it means to be on dialysis. How often do you have to go there, and how does it affect your own personal life?
I normally go once a month. Because I'm on peritoneal dialysis, I do it 4 times a day. Right. Every 4 hours I have to dialyze.
Okay. Where do you do this?
I do it at home.
At home? Okay.
Yes, I basically I do the function my kidneys is supposed to do manually. Right. I do it myself. That's what the dialysis do for me. Right. And it has been working like a charm since I started dialysis. The swelling has gone down. I don't get that tired anymore. Yeah. I can at least walk from here until, the gate. Yeah. So it has really helped me. And I try to, every month, I go on a monthly basis for a checkup. The doctor sees us on a monthly basis. Right. So every time I go there, the other patients that are there, I try and encourage them. Yeah. I try and motivate them, because this is a real lifestyle change. Right. What I've noticed is if you change your attitude, you can adapt. Right. And I have definitely changed diet. Starting from the attitude that I've changed, my diet has changed. I cannot eat the things that I used to. I cannot drink a lot of water. I'm limited to about 1 liter of water a day.
With a bit of help from your wife.
Yeah, of course, yes.
Well, let's speak to her. Imelda, what does it mean for you, to be looking after somebody with a chronic kidney ailment?
Well, the road is tough. It's very tough. Yeah. Because he was the breadwinner in the house. And now he's not. So we're struggling, but we're getting by.
Did he have to stop working because of this?
Yes, he stopped working because he was hospitalized every year. without fail. He was in hospital 3-4 times a year until they discovered that he had kidney problems, and till it was too far. Now his one kidney is not working at all, the other one is working 5%. And we spend most of our weeks at the hospital, 2, 3, 4 times a week, and it's costly for us. And also then his diet he has to follow. No salt, he has to eat certain fruits and veggies, and it's a lot. But with the support and the encouragement, motivation, we get him by, and he's getting healthier.
Yeah. And I mean, so you're saying that on the nutrition side, you're trying to limit salt.
Yes,
what else do you normally do?
No salt at all.
Yeah.
No salt at all.
Yeah.
The water intake is minimal.
Yeah.
It was on 500 ml, but now it's on a liter, and that includes taking tablets. In that liter for the day.
Okay. We'll come back to your lifestyle generally. I mean, just apart from nutrition. Let's speak to Josephine. Josephine, tell us about your story. You've been on hemodialysis for a while. So perhaps let's go back to the beginning. When were you diagnosed with kidney disease?
And in 2012.
2012?
Yeah.
And what happened then?
I wasn't sick before I could be diagnosed. I was just okay.
Yes.
It's just the feeling from me. You know, I said to myself, can we go to a doctor? I just need to go to a doctor. Why? Because I haven't been to a doctor for a long time.
So you just went to a doctor for a checkup?
Definitely, just for a checkup.
Right.
That doctor saw that my high blood pressure is too high.
Oh, okay.
And then she wrote a letter for me, and then she stamped it too much outside. She said, once I take it to the hospital, it will attract the sisters, and then they'll take me through the doctor. And it did when I went to Helen Joseph.
Okay.
So the doctor took my blood, I went to the lab, and then he told me just to stay, to wait.
Okay.
And
so before then, you didn't know that you had high blood pressure?
Totally. With the high blood pressure, I did know that I do have high blood pressure.
Right.
I was taking the pills from Santon City at the clinic.
Yeah.
I was just using those. But
and
now
were you
and then,
checking your blood pressure regularly?
Of course.
Yeah.
We supposed to.
Yeah. And was it normal or was it?
No, totally. It wasn't normal. It was high all the time.
Oh.
It was high all the time.
Yeah.
So they couldn't know what the problem was. Why? Because, you know, at clinics, there isn't any lab. They couldn't take any blood from me to draw blood from me, you know, to take it to there. But one day the doctor did that and took it to Hillbrow.
Yeah.
Yeah, while there's still a lab there.
Yeah.
And then when the results came back, it was funny. Why? Because the doctor didn't believe that. They said, my blood is like somebody who's dead. Yeah. She couldn't believe that.
Right.
But then, that was the results. She took the blood again, thinking that they've shaken the bottle.
Okay.
Yeah. And then the result came back again like that.
Yeah.
And then they couldn't know what was the problem.
Yeah.
By that time, I was working.
Yeah.
So I had to tell my boss what is happening at the clinic. So she took me somewhere else to see what is happening.
Yeah.
But the doctor also didn't tell me straight. They told my boss that everything is fine.
Right.
But I had this feeling that I could go to another doctor to, you know, just to see what the problem is.
So what were you feeling at that time? Did you have any symptoms at that time?
Nothing.
Yeah.
Nothing.
Right.
I was just okay.
And your legs weren't swelling or anything like that? Yeah?
No, but I didn't have those kind of things.
Okay.
Totally.
Right. So when were you then told that you have to start dialysis?
2012. Why? Because I went to Helen Joseph and the doctor told me that my kidneys are gone. Yeah. Then I started to do dialysis. Why? Because total, I needed that.
Right.
Yeah.
So you've been on dialysis now since 2012?
8 years ago.
How often do you have to do the dialysis?
3
and where
times
do you
a
go?
week in Helen Joseph.
Okay. So every week, Monday,
Wednesday and Fridays.
All right. Okay. And for how long at a time?
For 4 hours.
Okay.
Yeah.
All right.
Yeah.
And how has this dialysis issue affected your life personally?
It did affect my life totally too much. Why? Because I had to leave my work because I couldn't work at all. It was difficult to stay, very heavy. Yeah, but after leaving my work, I felt much better. Yeah, until now, while I'm doing this dialysis, I feel much better, really, truly.
All right. You don't feel any effect after the dialysis or anything else?
There is, but because it's been long, for 8 years, getting used to. You can't get used to totally, but, you know, gradually, you know, you get used to this dialysis. But it does have some effects after that 4 hours. You feel tired.
So we had earlier the issue around, you know, salt and so on. Did you have to change your lifestyle at all since that you've been?
Of course, you have to change your lifestyle. Why? Because some of the food, they've told us that some of the food you can't eat altogether. It's like a banana. If I eat the banana, my God, you'll take me straight to the hospital because I get sick, too much sick.
Okay, we'll get the dietitian to explain. What about alcohol? Do you take any alcohol, smoke?
Before, this was years ago, before I quit alcohol. I used to drink socially. But then when I found out about the diabetes, I had to quit alcohol.
All right, okay. Well, Caleb and Josephine, I want to thank you so much for your time. And, you know, it's not often that you get people willing to talk about their own personal circumstances, you know, disease-wise. And I want to thank you, firstly, for that and wish you well going forward.
Thank you.
Thank you.
And, of course, to you, Imelda, please keep up the good work. All right. I'm going to give you last 30 seconds.
30 seconds. I just want to, again, thank the people, the staff, the doctors at Helen Joseph Hospital. If it wasn't for them, I wouldn't be sitting right here.
They're doing a wonderful job.
They do.
All right. Thank you so much. Okay, well. All right, time for another quick break. When we come back, we'll try and focus on prevention of kidney disease. Please stay with us.
"29-year-old Michael Dlamini from Diepsloot presented strange symptoms out of the blue.
Benginokuvuvukala ebusweni, ubuso bami buvukala, amehlo angaboni kahle, ngingaboni nje into eqamama lapha ngayiboni kahle. Konke lokho kwangenza ukuthi ngisole. Uma ngimi isikhathi eside emsebenzini bekuvuvukala inyawo.
The diagnosis he received after visiting the nearest clinic shocked Dlamini.
Mangifika ekliniki bangithathe bangenze iBP. Ngangazi ukuthi ngeBP ngazi lutho. Babethi bayithatha iBP ayi 240 something. Ngendlela eyiphakeme ngayo. Ekuthiwa ngeke lento le ongunayo iBP yakhe high kakhulu. Mase kucheck ama result lawa ngeke ngafike ngazowathatha amagazi. Kutholakala ukuthi amakidney nalomuntu awavisi kahle, awekho mahle. So ngaleso sikhathi ke leso bangibizela iambulance. Bakhetha ukungifonela iambulance from Helen Joseph ezomthatha ngisele.
According to Dlamini, kidney disease was caused by high blood pressure and he had to start treatment immediately.
Kodwa ke bangichazela ukuthi amaphilisi engizowaphuza azoba maningi ngoba manje kuzama ukuthi kuliwe naloku iBP yona ngoba iyona eqale lento enginayo ikidney failure. So kwathiwa ke ngizofaka komunye umshini oyidialysis. Lo mshini lo ukhipha ama fluids ngaphakathi ngoba manje ongisakhona ukuya kahle etoilet ukuchama nokuya kahle number 2.
Dlamini's diagnosis impacted badly on him and his family.
Yeah, kube nzima kakhulu sisi, kube nzima kakhulu ngoba nginabantwana babheka isupport kimina njengobababo nasekhaya futhi bengusizo kakhulu emndenini wami. So lokho kungicindezele kakhulu ngoba nala eGoli la ngihlala khona la ngiyarenta futhi nokuya esibhedlela kudinga imali.
Dlamini has just been told that he needs a kidney transplant urgently.
I-transplant ngizoyidinga ngoba ngokungichazela kwami odoctor bathi ngiku-end stage ye-renal failure. Okuwukuthi ngisegcineni. I-transplant into ebaluleke kakhulu ngidinga ukudlula imali. Transplant ngoba iyona ndlela yokuphila kimina leyo.
All right, so to understand all about chronic kidney disease or just kidney disease, it's a great pleasure to welcome our guest, Dr. Zahira Kasimji. Now, Dr. Kasimji is a consultant nephrologist based at Helen Joseph Hospital. Welcome to Health Talk, Dr.
Thanks
Kasimji.
for inviting me.
All right. And next to Dr. Kasimji is Sister Gwendoline Cluster. Now, Sister Cluster is a kidney transplant coordinator also from Helen Joseph Hospital, and she's going to tell us a little bit about, what it entails to be a coordinator of kidney transplants. Welcome to Health Talk, Sister.
Thank you, Doctor. Thank you for inviting me.
All right. Dr. Kasimji, I think let's start from the beginning. Before we start talking about complicated issues around chronic disease, let's just understand the normal kidneys, Where are the kidneys? Where do we find kidneys in our bodies? What are the functions of the kidneys? Why do we need kidneys?
Okay. So the kidneys are two bean-shaped organs. They're about the size of your fist. They're found below your rib cage at the back.
Right.
And they perform very vital functions. One of the most important functions is to rid your body of toxic waste products.
Yeah.
And control certain salts in your body. Remove water so you don't get a lot of fluid overload.
Yeah.
And then they perform other functions that are not related to this, called endocrine functions or hormone functions. So they're very important in calcium and bone health, and important in preventing you from becoming anemic. So things to do with your hemoglobin.
All right. Okay. So what can go wrong then with the kidneys? We hear. Let's go through different terminologies. What's the difference between, for instance, renal disease and kidney disease and chronic kidney disease and so on?
Okay, so several things can happen to your kidney. So there can be what we call acute kidney injury, and that happens over a short period of time and is usually, hopefully, reversible. And then there's something called chronic kidney disease. So if this acute kidney injury progresses or lasts for very long, you develop what we call chronic kidney disease, and that's established. That's if you have this kidney problem for more than 3 months. There's several causes for the chronic kidney disease, and they range from diseases that can occur like high blood pressure and diabetes. So worldwide, probably, diabetes is the commonest cause of chronic kidney disease. And in our setting, it's most likely hypertension. And then we have other important things that cause chronic kidney disease in our settings, like HIV, certain drugs that patients may be taking, tablets that patients may be taking that can also cause chronic kidney disease.
We're going to come back because I'd like us to spend a bit more time on the causes. But how common is it? I mean, I shared some statistics, at the beginning. How common is the problem of chronic kidney disease in our country?
So it's common, but unfortunately we don't have exact statistics to tell us how many people have it. We think the prevalence ranges between, say, maybe 10 to 15% of the population do have some form of chronic kidney disease. Now, you mentioned there's over 850 million people worldwide that have it. So it's a common cause of morbidity and mortality in patients.
Right. And I'm sure people, watching this show would say, okay, so how will I know that I have kidney disease?
Sure.
Are there any typical presenting symptoms?
So like high blood pressure, early on, it's one of those diseases that are silent. You don't know unless you're actively looking for it or testing for it. And the ways to test it are things like a urine test that may pick up things like protein and blood, or you do an actual kidney function test. So early on, you may have no symptoms. Then later on, you will develop symptoms, like I'm sure our patients will tell you. You can get swelling of your feet, you can become short of breath, get tired very easily, things like itching and bruising easily as well. So those are the kind of features that patients present with later on.
And then obviously towards the end stage, so some people, you hear a concept of end stage kidney disease. Just take us through what that is.
So kidney disease is divided into 5 different stages, stage 1 to 5. Stage 1 and 2 and is quite early on. Stage 5, we look at something called your glomerular filtration, or GFR. It's crudely kind of like a percentage function of your kidney. When that drops below 15, we call that stage 5 kidney disease. When that drops even lower than that, patients often need dialysis. And end-stage renal disease is when it's very low. This GFR, the percentage function of your kidney, is very low. Your kidney is unable to perform its functions, and you usually need dialysis or a transplantation.
Okay. Well, talk about dialysis and transplants. This is where you come in, Sister Cluster. Yes. First of all, just take us through what your job entails as a transplant coordinator at Helen Joseph.
Okay, at Helen Joseph, I'm a recipient transplant coordinator. There is procurement transplant coordinators, and but I only work with the living patients. That's what. Okay. So I work with the recipient, the patient that's on dialysis, and the living donors.
Right.
So it can be related or non-related donors.
Right. But as coordinator, what does it mean? You go out looking for people, getting people to donate kidneys, or what exactly?
First of all, I work with the recipient, and I do give education. I educate everybody, all the patients, from the renal outpatients. And I see patients from stage 4 already, and I educate them. So once they start dialysis, we give them an option for peritoneal dialysis or hemodialysis. And I educate them through that period. And I start off by speaking to them about living donors. And they will bring forward their family and friends, as we have a big shortage of cadaveric donors. So we encourage living donors.
So you talk about big shortage. I mean, what is the actual need for kidneys? What are the sort of numbers that we're talking about here?
Currently, I have 166 patients at Helen Joseph, and it's increasing on a daily basis. So there is a big need, doctor, and we get like 5 transplants per year. So
Dr. Kasimji, I mean, perhaps this links to the whole question of saying, so do you have a national picture in terms of the actual need for transplants or, kidney donors out there?
Our South African Renal Registry actually does good work in terms of that, and they show us that currently there's about, say, just over 10,000 patients on renal replacement therapy. That includes a percentage that does receive transplantation, but the most part is patients that are on hemo and peritoneal dialysis. These are the patients that can access dialysis. Doesn't mean that it's the number of patients that need dialysis. So these are the fortunate few that can actually receive dialysis. And most of them would need, if they qualify, and by qualify I mean if they're medically suitable, they would require transplantation. Because what we can understand from this is that, dialysis is a bridge to transplantation. That's the ultimate goal of anyone with kidney failure.
Let's just come, I mean, the main thrust of this show, at least I'd like it to be prevention, because nobody wants to get to the point where you're on dialysis and you need kidneys and so on. Let's just go back to that issue of causes and perhaps start with the risks. Are there any genetic factors at play here, perhaps?
Yes, there are genetic factors, and especially in our African population, there's strong genetic factors that have been associated with both kidney disease and with the development of hypertension. And we know high blood pressure in our setting is one of the most common causes.
I tell you what, I want to bring in Sister here. Sister,
yes, sir.
In terms of, she mentioned, high blood pressure and so on. I just need to get a sense from your experience, the people that you're dealing with at Helen Joseph now. What are the sort of causes can you pick up there?
Mostly, as doctor said, I agree, it's hypertension. I work up a living donor, and immediately I will detect the patient is hypertensive. We cannot use the living donor with comorbidities. Hypertension, they do consider if the patient is on one antihypertensive. But most of them, I monitor them for 3 days, and then they newly diagnosed with hypertension.
Just staying on you a little bit, we're going to be talking to a few patients that are on dialysis, and we'll speak later on to somebody who's actually donated a kidney to, his own son. But just the other side now, how does chronic kidney disease impact, firstly, the patients and their families from your perspective? At least from your experience?
Psychologically, they are disturbed. Most of the patients I see initially is emotionally disturbed. They cry a lot. It's difficult to adapt and accept the disease because it's a massive lifestyle change for them. With they're restricted on their diet, fluid intake. So it's a massive change for them. Some of them lose their permanent jobs. So.
Okay, all right. We'll speak to, as I said, we'll be talking to a few of them later on, but I want to thank you so much for your time, sister.
Thank you, doctor.
Okay, guys, time for a quick break. When we come back, we'll continue our discussion on chronic kidney disease. Please stay with us. Okay, welcome back and thank you so much for staying with us. We're discussing chronic kidney disease with Dr. Zahira Kasimji, nephrologist at Helen Joseph Hospital. We're now joined by Shani Cohen, who's a dietitian based somewhere in Senton, and of course herself was previously at Chris Hani Baragwanath Hospital. Welcome to Health Talk once again.
Thanks for having me.
All right. Okay, so we need to start talking. I mean, we spent quite a bit of time early in the first segment talking about the risk factors and causes. We did that for a very good reason, because I'd like us to focus on prevention, in this segment. And perhaps let's start by talking about those at risk. We heard earlier there was mention of hypertension. In fact, a clip that we played, and one of our guests here also mentioned, the fact that they had hypertension, and the other one mentioned that, diabetes. So what's the general principle around screening for those people that are at risk?
So definitely those are very high-risk groups.
Yeah.
So it's important to, what we say is know your numbers.
Right.
Okay, so the numbers would be, firstly, you need to know what your blood pressure is doing, and it needs to be controlled. And in those patients, we would definitely do a urine test to see if we can pick up any early signs of kidney disease. And this is, stands true for both diabetics and patients with high blood pressure.
Right.
So if we see a bit of protein in the urine, we're already alerted that there's something going on in the kidney.
Okay.
Okay, and then there's a blood test that we can do to test your actual kidney function.
All right.
So for all diabetics and patients that have high blood pressure, they should have that done.
Okay. But I mean, we're saying, obviously we're talking about those that already have diabetes and hypertension diagnosed. But for everybody else, it's important that, they screen regularly. If they are at risk, for instance, people who have a close relative with hypertension or diabetes, what we're saying is that those need to check their numbers regularly and make sure that these conditions are diagnosed early enough. Correct?
Absolutely.
All right. On the nutrition side, I mean, let's talk lifestyle. I mean, we heard just how important lifestyle generally is on the nutrition side. For ordinary people that may not necessarily have, chronic ailments yet, how should they be going about their lives in terms of, the food choices?
So I think number one is maintaining a healthy, ideal body weight.
Yeah.
If an individual is overweight, they are at risks of diseases like kidney disease, diabetes, high blood pressure.
Right.
They need to focus on exercise, and they need to focus on the quality of their diet.
Right.
What are they eating?
All right, let's stay there. What should everybody be eating?
So I remember last time I was here, I spoke about sugar, sugar, sugar.
Right.
Now I'm speaking about salt.
Right.
Unfortunately, we need to limit the amount of salt in our diet.
Right.
The South African Heart and Stroke Foundation, as well as other guidelines, international and local, all recommend that we eat about a teaspoon of salt a day.
Right.
Salt is also called sodium, so we can use the word interchangeably.
Yeah. But that often is such a difficult thing, because some of the foods come with already, some serious amount of salt in them.
Exactly.
For some, and some people have salt at their table. So what exactly are we talking about when we say limit salt?
So it's the salt that we add to our food, but it also includes the salt that's already in our foods.
Yeah.
So basic foods like bread, which you would never assume has a lot of salt in, actually does have a lot of hidden salt in.
Right.
So we need to be aware of what has hidden salt in, and luckily our government is starting to implement laws that are forcing companies to start cutting down on the amount of salt that they add to our foods.
Right.
But us as individuals can also do things. So first of all, during the cooking process and while we're sitting at the table eating, we shouldn't be adding salt to our foods.
Right.
Instead of using salt to flavor our foods, we should use herbs, spices, lemon juice, other spices or herbs or flavors, ginger, garlic, onion, instead of using salt.
Right. But I mean, yes, we spoke about sugar earlier on, But that's still important.
That's still important, right? Especially for the weight maintenance part or achieving a healthy weight.
Right. And what are the general principles around there? What would your advice be to the public in terms of, staying away from sugars?
So my number one thing is avoid fizzy drinks completely.
Right.
A lot of our sodas, Coke, any of them, they have lots and lots of hidden sugars in them, more than what we would imagine.
Right.
Additionally, junk food like sweets, chocolates, we know we should be avoiding them.
Right. Everybody knows.
Everybody knows that.
Let's come back to, we're now dealing with people that are at risk of developing kidney disease, or at least chronic kidney disease. Let's typically talk about, hypertension, diabetes, and any other conditions. What should they be doing in terms of management of those conditions to ensure that, it doesn't progress?
Sure. So importantly, one of the most important things to prevent progression of kidney disease, if you have already established kidney disease, is blood pressure controlled. And that ties in very well with salt use.
Right.
So having a very good blood pressure, actually really good blood pressure. So we're looking for numbers, something like 130/85 for patients with kidney disease. That's what we would be aiming for.
Right.
Then good sugar control for the diabetics. And then we want to avoid certain other things, what we call nephrotoxins, things that can also affect the kidney.
Right.
And these are over-the-counter medications such as non-steroidal anti-inflammatories.
Yeah,
and
that's an important one. Everybody has a bit of an ache and, backache or whatever. So too much of these non-steroidal anti-inflammatories are not good for you.
Not at all. And they're also found in hidden places as well.
Right.
So certain flu preparations have a lot of non-steroidal anti-inflammatories in them as well.
Yeah.
Things called the gout cocktail that patients buy over the counter have quite a significant amount of anti-inflammatories.
Right.
And often when you couple that with certain blood pressure medications, if you take them together, an anti-inflammatory and certain types of blood pressure medications, the blood flow to the kidney reduces drastically, and we see a lot of kidney failure from that.
Right. There's this notion that, unfortunately this still exists, that you find herbal remedies, people that want to take with the idea that it cleans or cleanses their kidneys. Your advice on that?
So unfortunately, unlike a normal tablet that you and I take that's from a pharmacy that has to go through strict things like FDA regulation and phase 1 to 3 testing, I can concoct something in my own kitchen and call it a herbal medication and label it with anything and give it to you, and it doesn't require any testing, and that's the danger with it. We don't know what the actual preparation, what is in it, and if it's damaging to the kidney at all. And we do see it quite often. We see over-the-counter herbal and herbal medication from elsewhere causing kidney failure.
Perhaps the direct question is there a need for anyone to think of cleaning one's kidneys?
The short answer would be no.
No.
So these things come with other problems. The cleaning the system also causes dehydration when when that happens.
Yeah.
Plus taking a herbal supplement on top of that. These are the things that cause kidney injury. So the answer would be no.
So are there foodstuffs that, may be damaging to the kidneys, especially in those that are at risk?
So those that are at risk, definitely. So for example, for your diabetic patient, you should be avoiding sugars. For your hypertensive patient, you should be avoiding salt.
Right.
Additionally, not only from food sources, but also from multivitamins or supplements that individuals may be taking.
Right.
A lot of sportsmen are taking supplements that are also not regulated by any regulating body, and that can be quite nephrotoxic.
What about high protein load? Some sports people want to bulk up and so on and want to take in lots of protein.
Absolutely. So as we said in the beginning, the kidneys, one of the main functions is that it's a filter.
Yeah.
And when we eat protein, our kidneys need to help filter that protein out of the body as it turns into a waste product.
Okay.
If we're eating too high loads of protein, there's too much waste in our body, and our kidneys are forced to overwork.
I think it's a good point for us to pause there. We're going for a quick break. When we come back, we talk treatment of kidney disease. Please stay with us. Welcome back. We are still with our guest, Dr. Zahira Kasimji, a nephrologist at Helen Joseph Hospital, and Shani Cohen, dietitian, and we're now joined by Frank Borges. Now, Frank is a related living donor who's donated a kidney to his own son. Welcome to Health Talk, Frank.
Thanks for having me.
All right. I'm going to come back to you just now to learn more about your story, but let's just speak to Dr. Kasimji now. Let's talk principles of treatment. We've heard a lot about hemodialysis and transplants. And let's start with hemodialysis. Firstly, take us through the differences between hemodialysis and peritoneal dialysis, and at what point in the chronic disease journey does one require dialysis? And of course, we'll talk about transplantation as well.
Sure. So remember, we said there's 5 stages of kidney failure. So when you're on the last stage, stage 5, and your percentage function is less than 15, you start to develop some symptoms of kidney failure, the tiredness, the swelling. When it goes much below that, often below 10, or when a patient has lots of swelling, or the gentleman earlier said he couldn't breathe because of water in the lungs, we like to do dialysis a little bit before those complications happen. Okay, so we want to preempt those. So that's when we start dialysis. So there's 2 main types of dialysis. We say hemodialysis, and there's peritoneal dialysis. So hemodialysis is dialysis through the machine, as you may all be familiar with. So the first thing you need before dialysis, you need what we call vascular access. So you need a way for your blood circulation to get purified through the machine. So that's the first thing that needs to happen for a patient. So
and what does it entail?
So it entails seeing a surgeon, a vascular surgeon, and getting something called initially what we call a permanent catheter in. So it's a tube that goes into one of your big blood vessels, and through that you connect it to a machine. And then down the line, patients get things called fistulas, which is actually a connection of your own vein and artery together, and a needle goes into that. So that's the first principle. So what happens when you get connected to the machine, it's usually 4 hours, 3 times a week, and it performs some of the functions of the kidney. Okay, it can't replace all the functions of the kidney, but it performs some important functions. So getting the acid-base balance right in the body, getting rid of dangerous electrolytes like potassium that can get very high, and it can also get rid of water. So patients don't get buildup of water in their lungs or swelling in their legs. So that's hemodialysis.
All right. And peritoneal dialysis?
So peritoneal dialysis, so there's a plastic tube that's inserted in the patient's abdomen, and the inside lining of the patient's abdomen is like a dialyzer. It's used as a filter. So they instill fluid into the abdomen. This fluid contains a lot of good things to neutralize high acid levels and to pull out water. It stays in their tummy for 4 hours, and then they self-dialyze, or they drain it after 4 hours. So they drain out all the bad things, and they're able to instill some good things to restore, say, the acid-base balance in the body.
Okay. So do people have a choice that I want peritoneal as opposed to hemodialysis?
Ideally, people should have a choice, but unfortunately in the state sector, we are constrained by resources. So it all depends where there are slots available for either peritoneal or hemodialysis. They're both equally as good as the other. The advantages to peritoneal dialysis is that you are able to do it at home. You don't need to come in 3 times a week. And the hope is that you're able to still live a productive life where you can work and things like that.
All right, all right. And then, of course, at some point or throughout that period, people need transplants.
Sure.
All right. When is that determination made? When dialysis starts?
So once
and who qualifies, by the way?
So once we've established that you have chronic kidney disease or end-stage renal failure and you're on dialysis, you would ideally require a renal transplant. And because dialysis doesn't perform all the functions of your kidney. If you can think about it, it's 4 hours, 3 times a week out of a whole week that it's performing the function, whereas your kidney is working all the time. So it's not the same. Patients on dialysis also have a lot of complications that can arise because the kidney is not, working to its full capacity. So transplantation is the goal. The patients that qualify are patients we have a rigorous testing system. You have to be medically fit to qualify for transplantation. Okay. So patients undergo lots of testing before that: heart function, bladder function, lung function. They need to be fully healthy otherwise to qualify.
Well, let's talk about one such person that donated a kidney, Frank. Frank, and thank you very much for your time. Just tell us about your own situation. Your son had obviously chronic kidney disease, and you were called upon to assist. Just take us through the story.
We didn't even know he was ill.
Yeah.
Just the last 2 weeks before he went into hospital, he was just sleeping a lot. There was no swelling, there was nothing, he was just sleeping a lot. And the Thursday evening, he said he couldn't lie down, he couldn't sit up, his kidneys were probably sore. And my son then took him to hospital that evening, and to the Ellen Joseph, and they left him there for the night. And the Friday morning they told us that kidneys weren't functioning. And I think by the Tuesday he was already on dialysis the following week.
Yeah.
So this was all sort of new to me, and this is when I met Sister Gwen, and she gave me different options. Either Ricardo must wait for a kidney, or there's other options where a family member can donate.
Yeah.
And I said, well, I'm here.
Yeah.
Let's
and how long after starting dialysis did this conversation about transplant, start?
Within a week.
Okay.
Within a week.
So it was quite early on, yeah?
Yeah, I was straight away. I wasn't going to waste time.
Right, right. And how old is your son, if I may ask?
He's 26.
26. All right. And this happened about 2 years ago, so he was about 24 at the time.
Yeah.
All right. And just what did it mean to you? I mean, how easy or how difficult was, the decision taking?
For me, it was easy because he's my son.
Right.
There's no ways, as a parent, I'd want to see my son suffer.
Yeah.
And have to, worst case scenario, pass away or something like that. And I said, well, I've lived my life. If anything has to happen, let it happen, but not to him.
Right.
And then they did the tests.
Right.
And I said, let's just go and stop wasting time.
So you obviously had to go through tests and so on. And it's been 2 years. What does it mean to you now?
Well, I see my boy, he's back to normal.
Right.
And, it's, you have a sense of pleasure, this is what I aimed for, and I achieved it.
Right. And you now, what does it mean to you now that, you're only left with one kidney, so to say? Did you have to adjust your lifestyle in any way?
No.
Why not?
There's no need to.
Right. Is that what you advised?
I've learned through the time with the sugar and the salt and that you don't abuse the stuff.
Yeah.
And that's how we've, already with Ricardo in the beginning stages, my wife was cooking different. And it's become a habit.
Right.
The one good thing as well, when this all happened, I stopped smoking as well.
Yeah.
And but we don't abuse us.
Yeah.
We don't.
You're still looking well after yourself.
Yeah.
Well, before we run out of time, Shani, let's talk about the role of nutrition now in people that are undergoing dialysis and post-transplantation, as it were. I mean, we heard earlier that they can't even eat bananas. Your comment.
Exactly. So the reason why you can't eat bananas is it contains a mineral called potassium.
Right.
The kidney, again, filters out all food products, and some of the food products can be toxic if not filtered out enough.
Right.
So potassium, phosphorus, sometimes calcium, and protein are the ones that we need to look at the most.
So let's give some examples. We mentioned bananas. Any other foods that these people need to be avoiding?
So bananas is for the potassium. Maybe we can look at the phosphorus because those are usually the foods that we eat more commonly.
Right.
So usually we're all told to eat brown bread or whole wheat bread. Unfortunately, they're quite high in phosphorus.
Okay.
So in this instance, we actually need to turn to the white bread, which is a bit lower in phosphorus.
Right.
Also in terms of I was speaking about sodas early in terms of colas.
Yeah.
A lot of us do drink fizzy drinks, so if you are going to drink a fizzy drink, try and not drink the dark coloured ones.
Yeah.
Rather go for the see-through or lighter coloured ones because they'll have less phosphorus.
Okay. And of course, everybody has to look well after themselves, and we're living in very difficult times, and you know, there's the coronavirus scare around us. And you folk at home, just to remind you to please, yes, we understand the concern around coronavirus, but please do not panic. Just follow that basic principle of washing your hands as regularly as you can. No need for a mask, because the mask is not going to, you know, protect you from getting the infection. Just basic hygiene, social distancing, washing your hands as regularly as you can, either with sanitizer if you can have access to it, or just simple water and soap. Back to you guys. Thank you so much for your time, and especially to you, Frank, and of course, for all the information and the knowledge and the good knowledge that we got from you. And you guys at home, thank you so much for staying with us. We're back with you again in a week's time. And until then, please do take care.